So now we're moving to our very last item on the agenda, and it's the future of cancer care. It's an excellent presentation by Dr. Andrew Feifer.
Hi, everybody.
I'm going to okay.
Can you see my screen okay?
I can see you. You got to share your screen.
Okay, let's see. I'm going to share the screen right now. Hold on. Can you see my screen now?
Yep, there you go.
Fantastic. First of all, Ken, I just want to congratulate you on a wonderful meeting thus far. I wanted to say hello to some of my friends who are on the panel, Andrew, and it was great to see Robin Roberts again. Last time I saw Robert was when I was in Antigua giving a talk there years ago, and it's nice to see everybody, and it's a real thorough pleasure for me to come back. It's been 7 years since the last time I had the opportunity to speak at the Walnut annual meeting, and it's been way too long, and it's disparity medicine with respect to prostate cancer is a very important part of what I do, and it's a thrill to be back here. So thank you very much for giving me the opportunity. So I'm going to talk to you a little bit about something called NED, which is a project that I conceived of years and years ago. It's amazing. It's been going on for about 8 years now, since 2012, and it is a project that has brought together great people in across Canada who provide care for prostate cancer patients, and it has taken off recently for numerous reasons that I'll go through. For those of you who don't know what NED means, NED is not just a simple acronym. When I was sitting down trying to come up with a name for this, a good friend of mine asked me, "So what do you write, Dr. Feifer? What do you write in the chart of patients who are survivors for their cancer?" And I say, "Well, there's a medical acronym I use." They said, "What is it?" I said, "It's NED, no evident disease." So when going through the branding and the name for this project, I don't feel there was anything more suitable than calling it NED, which is no evident disease. So let me just move on here. So the first thing, obviously, we had some great talks by Robert and Andrew and others this morning talking about prostate cancer. Prostate cancer remains a very big issue. It's been plagued also by poor uptake of screening, particularly in at-risk populations, the African American, African Caribbean population, for those reasons that we've discussed earlier on. It remains a very significant health risk in Canada and a more significant health risk in the US because of numerous things having to do with race-based medicine and so on. But also having traveled in the Caribbean myself, trying and experiencing the stories of Caribbean men with prostate cancer who are both being overtreated and tremendously undertreated and not screened at all, it represents a very, very big problem. So just to reiterate, this is the reason why, some of the reasons why we came to come up with this program with NED. So my question to you is, why do we need innovation for prostate cancer? And a lot of the work that has been done, specifically in Movember and so on, with Andrew and Jackie Bender, who's part of, who are part of our NED program, also have really highlighted the fact that we are not doing a really great job right now. How are we doing? Not so good. We have the U.S. and Canadian task force recommendations that have since been similar, almost recanted a little bit to go from grade D evidence to grade C recommendation and so on. There's poor uptake in at-risk populations of screening and good treatment and good counseling. We've recently had COVID-19 and a lack of face-to-face visits, which we'll talk about in terms of the impact and how we can mitigate that. Lack of funding for information campaigns, difficulty getting populations to embrace new forms of treatment and new paradigms of treatment of survivorship. And so what do we need to do to fix this? Well, some of the things that we could do are more information sessions about risk-benefit situation for treatment and screening, more education, such as conferences like this, innovative technologies to help men get screened and followed for prostate cancer, more opportunity for an outreach to at-risk populations, leveraging common technologies, things that people use for men's benefit, and of course, more urologists and family doctors taking screening seriously, a very important thing. So with all this, we didn't need this, and Corona hit. And Corona is a major, major, major issue. Of course, we all are experiencing this, and it has further impacted the screening and treatment for men for prostate cancer. As a prostate cancer surgeon in Ontario, I wasn't doing prostatectomies for 4 months. I was not doing in-person screening with digital rectal exams before we knew how to protect ourselves from COVID. I wasn't doing it for several months as well. It became a very big issue, and that also has contributed to disparities in prostate cancer screening, management, and so on. So, were we prepared for this as prostate cancer providers? Probably not. We didn't know how to do, pandemic medicine with respect to prostate cancer, and we're still learning how to do it. Most of us are still learning how to do virtual medicine properly. We were given the opportunity to do virtual medicine 2 or 3 months in to the pandemic. So most of us had not done. I had done research in virtual medicine for years, so I was a little bit more comfortable than the average person, but many of my colleagues were caught flat-footed and didn't know how to react to the pandemic in terms of how to help men with prostate cancer if we didn't need another barrier or obstacle in our way. So some of the pain points of the current standard of care are, survivors lack the tools to access health information. Now, what do I mean by survivor? I want to be very clear about this. Survivorship for prostate cancer starts on day 1. It is the first day they're diagnosed. The survivorship platform that Andrew Matthew and Movember and others have created thus far is important and highlights the fact that the care for men with prostate cancer happens the day they get diagnosed. Starts that day. It becomes emotional, psychological, physical, of course, and all the other things. So there's a tremendous lack of access to health information and specialty care, especially people who don't live in near centers of excellence for this. And specialists are managing prostate cancer survivors with a lack of insight into their patient's health status and follow-up between appointments. And I can speak from experience here. My clinics are overpacked. There's a lack of ability to optimally prioritize patients. And patients are not simple. As we saw from the video before, there are complex needs that need to be met. And we are not doing a great job at this point in time. So NED, as I mentioned, stands for No Evidence Disease. It's a prostate cancer survivorship platform that I looked at, and I've since partnered with some wonderful people that really helped me carry this together as a team. The NED virtual clinic is built upon the NED platform, which aims to transform the traditional model of survivorship care through virtualizing services. Now, this is not instead of Movember. Nothing could be further from that. Movember and NED are working hand in hand to leverage each other's benefits and strengths, particularly within the Canadian health ecosphere, and then moving forward towards hopeful inclusion of other major important sites. I remember the map that Robin showed this morning of the islands that comprise the Bahamian country or Bahamian Islands, and I think that's wow, wouldn't it be amazing for Robin to sit in his office and to deliver virtual care in a risk-adapted, evidence-based manner to his patients on different islands? And just because you live in a certain remote part of the country does not mean your care has to suffer. That's what we're after. So NED has an asynchronous virtual care model component to it, meaning that a patient completes a lab test, a PSA test. Robin had talked about that in terms of screening, testosterone if necessary, and a wellness survey to understand really what makes them tick and how they experience their disease, how they experience the symptoms of their treatment of their disease, whether it be radiation, whether it be hormones, whether it be surgery, or a combination therein. We want to know truly how people are doing. As a physician or as a nurse practitioner or other Professionals or providers, they review the lab test, review the survey results, generates a care plan with a synoptic report, which means a very standardized approach to management of those patients. The doctors schedule a synchronous video phone call with select patients as needed, and the patient reviews the care plan with the physician or with the PA or nurse practitioner, and continues to completing lab tests and wellness surveys according to their surveillance protocol. What this means is that you don't wait for months and months and months to speak to your physician. You have answers right there at your fingertip, utilizing technology that you are comfortable with, meaning your smartphone, your laptop, a desktop, a BlackBerry, even if it can be accessed through any which way. And having toured some of the Caribbean islands and looking at prostate cancer as a major health issue, I was amazed that people were not getting prostate cancer screening, but everybody seemed to have a smartphone. So it's unbelievable how you can reach people utilizing the things that have been common in our life right now, such as smartphone technology. So just the way the information flows, the patient receives the lab requisition, it completes the lab in the community, and these community lab, at least in Ontario now, are standardized, so we can pretty much send them to anywhere they want. We obviously have to make country and territorial or geographic alterations to that to see how that fits. Those symptoms, the patient reports the symptoms, the physician or the provider views these, develops and sends a care plan. The patient receives the care plan here, schedules a video call, and that is done in an asynchronous manner. So also what's important here is that when you like I have NED clinics in my practice right now. So I've built in hours a week where I speak to patients virtually right now for their prostate cancer care. And, it's great to have the opportunity, schedule time to see patients. Patients don't have to come in and risk, exposing themselves to COVID, in different way of different parts along their path in. They get to talk to me. We get to establish a relationship, understand where we're going, and it's done in a very convenient fashion for patients and providers. So this is sort of how the patient application looks. There's a nice timeline. This is just a welcome screen that allows people to know where they are, what they have to do, whether they have results available, the surveys are available, the prostate-specific antigen or the PSAs are available, and then you basically get this report from the physician and say, here it says, "Hi, Greg, I reviewed your symptoms and lab reports. I have no concerns at this point. I don't think a video is necessary unless you have an outstanding question or concern. Here's your follow-up, but please call me and schedule a virtual visit if you want." So different situations require a different level of care. It allows me as the provider to streamline my care to patients that need me, and allows the patients to say, you know what, I'm not going to go travel 45 minutes or an hour to go see my physician for him to tell me that my answers are okay and my labs are fine. So it really streamlines things. So this is the clinician dashboard. This is what I would see. I have all the great thing about this is that, especially in the setting where we're doing a lot of virtual care now in the setting of COVID, NED and the platform allows me to do things in a evidence-based manner. All of the information that I need for my patient, provided I don't have to examine them at that given point, right, which is different, okay, is provided there for me and allows me to see the treatment plan and whether or not the patient needs intervention for things like incontinence, erectile dysfunction, depression, all these things that are key survivorship points for patients with prostate cancer. So there's really, an opportunity to enhance the NED virtual clinic. What we did, we were thrilled. The Canadian Institute of Health Research and the Canadian Cancer Society granted our team, which is a pan-Canadian team now, $2.5 million for a project grant, which we were thrilled about, of course, to develop this further and take this to a nurse-led algorithm to enhance NED survival. So it's not just because I operate on prostates that I can make decisions on what a patient needs. We've really piloted and pioneered a nurse-led virtual clinic across Canada. We have multiple jurisdictions, including Vancouver, Alberta, Eastern Canada. Right now, just going back to Robin's treatment routes at Dalhousie, we have Dr. Ricardo Rendon, who's a good friend and a prostate cancer expert on the eastern part of Canada, now contributing to this. And we have great data coming in, and we started the build. So it's really an exciting thing. The nurse-led survivorship model really focuses on a nurse sort of broadening the scope of care for patients, being able to speak to your prostate cancer specialist, other health services, primary care doctors, and of course the patient. So this is a really exciting thing. The exchange of information is also optimized. If I share a patient with Andrew Matthew, for instance, and Andrew is contributing to the wellness of my patient in the survivorship post-operative platform, for instance, this will allow Andrew and I to communicate seamlessly without delay, and to have the patient receive the right information, the patient take ownership of that information, and for myself, Andrew, and others to understand the complete picture of what's going on for patients in their survivorship. So basically, doing this, we also created a 3-week nurse curriculum composed of diverse learning activities. So the nurses who are doing this, who are going to be doing this, are trained tremendously with respect to how to interact with prostate cancer patients. Now, this includes opportunities to speak to patients from diverse racial backgrounds. Being able to speak to patients with particular concerns based on their heritage. And that's a very important thing. Leveraging the great work, of course, done by November also is also an important part of this training. So very, very exciting opportunity here. So basically, the NED algorithm does really assist the NED nurse with the capacity to remotely manage the care for survivors. It processes relevant survivorship indicators, aggregates a learning data set, all the things we discussed before, and generates also feedback messages to NED to direct the NED nurse to care patients who are most in need. So that's an important thing. So right now, for the NED implementation, we have 5 sites. We have 3 nurses, 5 NED specialists, and 600 target patients over 4 years. Being an academic urologic oncologist, I believe that creating a solution for these things does not, it's not just create it and set it. I mean, this thing costs millions of dollars to build, and we can't just send it out and hope people use it. It needs to be studied, it needs to be fine-tuned. There's patient input and provider input every single step of the development. So this is a well-tuned, as I mentioned, risk-adapted, evidence-based virtual care platform for prostate cancer that we hope, very honestly, will be able to heighten the quality of care, augment, the quality of care, and put everybody on the same playing field. So this is just a little bit of the timeline, how it started. It started when I won a hackathon in 2012, believe it or not, as just an idea. And of course, things snowballed at that point, and had developed different grants and different opportunities to partner. Very exciting, and this is where we are. It's NED 3.0, a virtual clinic right now, and I, just like everybody here, wish that the COVID-19 pandemic would never have occurred. It has changed my life. It's changed my family's life, my patient's life, and I hope it's over soon. One of the things that will not end regarding this pandemic is the need for virtual care. Patients have recognized that it's not hard to receive great care virtually. Now, it's important that as Robin said before, if you're being diagnosed, if you're at high risk for prostate cancer, it's important to get examined. So NED is for patients with prostate cancer and patients who need to be screened for prostate cancer, who need a necessary physical exam, such as a rectal exam, are not ideally suited for NED, at least not yet. God forbid they get diagnosed with prostate cancer. NED can be a big part of their treatment scheme or treatment algorithm, but it's not for the screening population. It wasn't designed, because we obviously can't examine patients virtually just yet. Maybe will come in the future. So just one thing about this is our timeline. And because NED has been so successful so far with prostate cancer, and the data that have come out of the application and the research so far has been great, we've included 2 new disease sites in this. First is breast cancer. So breast cancer is a major public need as well. And the same virtual care that's possible in patients with prostate cancer is entirely possible in patients with breast cancer, leveraging different technologies and helping women get through their survivorship in all the very specific and personal survivorship items that comprise a very astute plan for breast cancer survivorship. And we also have testicular cancer as another one. Being a urologist, I see this as well. And Dr. Rob Hamilton, who's a colleague of mine, we trained together in New York. Had come up with a great opportunity to do this testicular cancer application. We've now sort of come together, which is very exciting, leveraging our advances, his advances and our advances in the NED team to create a testicular cancer project as well. So we are super excited about this, and we very much hope that that this technology will filter down to Canadians, Americans, African Caribbean individuals, those people and providers, and stalwarts of prostate cancer care like Robin Roberts, who are doing great work all over the world, and hopefully this will serve as an opportunity to engage people of Black heritage or Black ancestry to be more engaged in clinical trials, more engaged in self-awareness, and provide another virtual and more suitable, perhaps more private opportunity to speak about those important things that are plaguing their survivorship. So that's the innovation we've done. I'd like to thank the fellow panelists for providing some great information earlier today, and I'd like to thank the Walnut Foundation for allowing me to participate. And I'd be happy, as long with the other panelists, to entertain further questions.
Yes. Thank you very much, Dr. Feifer.